Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Today's program discusses neurosurgery and trying to dispel some of the myths of the brain and neurosurgery. Sometimes we think of neurosurgeons as these magicians who play with people's brains, and I have one of them with me here today. It's my pleasure to introduce Dr. Douglas Cohen, the Chief Neurosurgeon at Richmond University Medical Center. Welcome.
Thank you.
So let's start from the beginning. Why did you become a neurosurgeon?
For me, it was actually an evolution. I went to medical school, very interested in the brain, thinking I was going to be a psychiatrist. And through my experiences and my rotations, I became enamored of neurosurgery, what a neurosurgeon can do, how a neurosurgeon can help, and so I basically transitioned and became interested in pursuing that as my career.
Interesting. I became a neurologist, and I think for many of the same reasons.
Really?
Except I wasn't as good with my hands.
Right.
And I always felt that your soul was in your brain. That's the one thing we can't transplant.
Well, I think it was Descartes who thought it was in the pineal. So I don't think anybody has actually been able to dispel that completely, but I don't think we know where the soul is quite yet.
So let's talk to everyone about how long it takes to be a neurosurgeon. What kind of training does it take to be a neurosurgeon?
Well, obviously there's 4 years of medical school, and in neurosurgery that's followed by a pretty extensive and rigorous residency or postgraduate training program. Tends to last between 6 and 7 years, depending upon which program. So that's 11 years following graduation from college. But even then, you're not even eligible to be what's known as board certified. You have to be out in practice for at least about 18 months before you can even sit for your board. So it's a very long process, but as I've told many medical students and even pre-medical students who are interested in it, if you're not interested in the science of it, if you're not interested in the practice of it, if you're not interested in really the education about it, then it's probably not worth it, because it's too long a road to look kind of far off and say, okay, that's what I want, because really you're getting it the whole time. And if you're enjoying what you're doing, then it's all part of the process.
And I think that's part of whatever any one of us does. I mean, any profession, as a neurologist, as a neurosurgeon, you have to love what you're doing.
Right.
Love your patients, love the science, love all the aspects of what we're dealing with on a daily basis. And there's been so many improvements, so many new things going on in neurosurgery. Neurosurgery wasn't common 200 years ago, even 100 years ago. And the idea that we've got so many newer techniques and different things to make neurosurgery a safer procedure. So for people out there who don't know what neurosurgeons do, I mean, we think about the brain, we think about different areas, and as a neurologist, I refer to neurosurgeons all the time. Maybe give me a little bit of an idea. What type of procedures do you do? What kind of surgeries do you do?
Well, broadly in neurosurgery, you could kind of definitionally describe neurosurgery as surgical treatment of the nervous system. And that can include both the central nervous system, meaning the spinal cord, the brain stem. Additionally, to a certain extent, the peripheral nervous system, the nerve roots and the peripheral nerves. So whenever there's a pathologic process, whenever there's a disease process that has been shown to benefit from surgical intervention, that's most likely the type of patients that will be seen by a neurosurgeon and hopefully helped.
And in broad terms, things like brain tumors, aneurysms, herniated discs, I mean, all kinds of things that we're going to talk about over the half hour that we're together. But they're all different, and they all have different skills and different skill set to do. Let's talk about one in particular. It's so common right now with different injuries, athletics, work-related, car accident-related. People get what they call a herniated disc. And as a neurologist, I look at a picture and I see something bulging out. I know we have some models here to show, but that's such a common term. Herniated discs, bulging discs. What treatment, how do we go about treating someone with that kind of problem? What do you see?
Well, initially, if we can just, if I can refer to the model, a herniated disc is essentially the spinal column is made up of alternating vertebral bodies, which are bones, and then essentially the joints between those bones in the spine are specialized joint spaces called discs. And those discs, depending upon what stage in life you are, can be almost soft and kind of gooey, or very hard and grizzly. They tend to get drier as we get older. But in any case, that disc can push out and essentially go into a place where it doesn't belong, the so-called herniated disc. And because of the anatomy of the spine, what is depicted here in these little kind of plastic sprigs, these are the nerve roots. And what's depicted here in this kind of red area is that the disc that is herniated can push on a nerve root. So that kind of in a broad sense is what a herniated disc is and why sometimes it comes to treatment by a neurosurgeon.
So when someone comes in, and I'll take my part of it, so someone comes into my office because they hurt their neck or they've got neck pain, even without trauma, low back pain, and it's going into one arm, and there's some numbness, some weakness, and we examine them, whether it's a neurologist, orthopedist, internist. Oftentimes we'll get test pictures in order to see what's going on there. Some of the tests we do might be an X-ray, but really more advanced testing and imaging over the last few years include a CAT scan, which is another kind of an X-ray, as you know. And then we start dealing with tests like MRIs, which basically give us a lot of pictures of soft tissue. So when you show that herniated disc there, would that be seen typically on an MRI or a CAT scan?
Yeah, really, I think you can see it on a CT scan, but really the gold standard today is the MRI. And that's because the MRI, unlike the CT scan, really shows soft tissue in very good detail. And what this is, both the disc as well as the nerve root, is soft tissues. X-rays will not show them at all. However, certain software packages on a CT scan will give you kind of an inclination or an intimation that there may be a herniated disc. However, as I said before, really the kind of gold standard at this point is the MRI. Mm-hmm. Those are really kind of the diagnostic tests that give us anatomic detail. In other words, they give us pictures of what is going on, where the nerve root is and where the herniated disc is. Some of the other things that we occasionally rely on, and something that frequently you will perform, is the neurophysiologic test that will tell me, well, is this nerve root working? Is this nerve root delayed in its transmissions? Is this nerve root not transmitting the way it's supposed to? That's going to give me essentially a functional idea of what is going on in the nerve root to kind of hone me into an area that may be the source of the pathology.
So when you have a herniated disc, and we'll go back to real people talk, it's a pinched nerve. And what's happening is, as you were showing there, is the disc is actually hitting that yellow material called the nerve. And what you're looking to see, what I'm looking to see as a neurologist, is whether that nerve is working or not. Now, a lot of people are walking around with herniated discs, bulging discs, protruding discs, not all synonyms based on really how far the disc is out of place. Most of my patients, and I'll talk about from my point of view, but I'd like to hear your perspective, don't need surgery. Most people are treated conservatively with physical therapy, maybe an injection or something like pain management to reduce some swelling. What tells you that someone needs an operation?
Yeah, that's actually an excellent question, because the lion's share of patients with herniated discs, whether in the lumbar spine, which is what we've been talking about, or in the cervical spine, as you had referred before, giving you neck pain going out into your arm, the overwhelming majority of those patients really can improve simply based on more conservative treatment, based on physical therapy, pain management. And essentially, in the overwhelming majority of cases, that's kind of the hierarchy of treatment by which we treat these patients. We first want to expose them to the less aggressive, potentially less risky procedures like the conservative management and the physical therapy. And that is not to say, by the way, that routine neurosurgery is risky. However, there is a different risk profile once you're going under anesthesia for the simplest of operations that is clearly different from a non-operative intervention. So we try to exhaust the non-operative interventions before we start to explore the more aggressive operative intervention.
So no one's rushing to do operations on patients unless they have severe weakness or such severe pain that they can't function. But usually it's weakness or other neurological symptoms like bladder problems.
Correct.
Then sometimes we'll do it.
Essentially what I'll say to the patient then, and it's not a diagnosis that I would ever want to make on a TV camera. It's obviously something that you have to refer to your doctor about. But when you're demonstrating evidence of nerve damage, that the nerves conveying muscular strength, the nerves conveying bowel and bladder function are not working. That becomes more of an acute situation, a situation where we have to treat things quickly, because the one thing about the nervous system generally is that once tissue in the nervous system dies, it doesn't recover. So we want to jump on that as quickly as we can.
And we clearly can't guarantee that they'll get better.
Right.
That's always a problem. Maybe just going over a little bit of anatomy, since we have such a wonderful model here and we so rarely have the opportunity. Could you explain, and there are discs between all the vertebrae,
Right.
and that goes all the way up into your neck.
Right.
So if we could just go over some things, because everybody thinks about the lower back having a herniated disc.
Right.
I think less people think about the middle back, or called the thoracic spine, or the cervical spine having herniated discs. And maybe just go over a little bit of the symptoms someone would describe if they came in.
Right. Well, as we've referenced earlier, herniated discs in the lower back are generally going to give you lower back pain, as well as pain that may radiate down into your legs. There may be pain, there may be numbness, and as we referred earlier, even a little weakness. In the cervical spine, which is essentially the spinal cord up in your neck, those same nerves are going to your arms. So you can get pain in the neck, no pun intended, as well as pain going down into the arms, also numbness and tingling. The thing that's a little bit different, and I guess we can invoke some anatomical explanations, in the lumbar spine there are only nerve roots. The spinal cord actually ends right up at the top of the lumbar spine. So by and large, disc herniations in the lumbar spine, not every one of them, but most of them are going to be pressing on a nerve root. In the cervical spine or in the neck, when a disc herniates, not only is potentially a nerve root in jeopardy, but the spinal cord is in jeopardy. And when the spinal cord is compressed, there can be a whole host of other problems, a whole host of other symptoms that again indicate to us that things need to be done more quickly and more aggressively. What many people don't understand is a disc herniation, I hesitate to say in the right place, but I'll call it in the wrong place. A disc herniation of the cervical spine in the wrong place can affect walking, can affect your legs, and can affect bowel and bladder. And it's just secondary to the anatomy of the central nervous system. And then I'll spend a little time just on the thoracic spine that you had referred to before. That is the part of the spine, just as it sounds, that is essentially attached to the ribs. So it's part of the spine that's in the thorax, or the back of the thorax. It's very rare to get a disc herniation in the thoracic spine. However, thoracic spine disc herniations are known as the great imitators, because patients can come in sometimes complaining of belly pain, and it can be a disc herniation. They can come in with a whole host of lower extremity problems, weakness or pain or numbness that doesn't necessarily map out as specifically as we would expect. And they tend to have they can have thoracic spine problems. It's a much more difficult diagnosis to make, but it's one that like the other ones, sometimes can require a very urgent intervention.
I know we've only talked about spine so far, and we could talk about the spine for hours, the spinal cord, the nerve roots, the bladder function, the weakness that could occur, and really how important it is really to be on top of an injury there. As you said, there are people who I've seen who've had chest pain related to thoracic spine problems, because this is around the area where your heart would be.
Right.
So tell me, what kind of a team, as a neurosurgeon, you're different than other people. You need a team. You can't walk in and do surgery by yourself. You have to have nurses and people in the intensive care unit, neurologists, all kinds of different people. Tell me about the team that you've amassed out here.
Well, that's absolutely correct, and really the team or the neurosurgical team that we would be invoking start even before you get in the hospital. The assessment, the preoperative analysis and clearance require specially trained nurse practitioners, physician's assistants to basically go through some of the issues. Because of where we operate, because spaces are very small, and because we're dealing with things that cannot be compromised with compression and bleeding, specific issues like being on aspirin or Advil are things that can sway us in making a determination whether or not surgery can be done in a particular time frame. But that becomes even more specific and more important as we actually face the surgical intervention itself. That includes the nurses in the operating room, the technicians. We will frequently use what is known as intraoperative neurophysiology, essentially an intraoperative application of the test to which I referred earlier, for which I refer patients to neurologists, that will tell us in the operating room, as a patient is under general anesthesia, that his or her spinal cord is working, essentially functioning well. So we will have neurophysiologists. There are particular techniques and particular instrumentation that we may discuss a little bit later that also require very specialized personnel to be involved. And then finally, and probably most importantly, post-operatively, in the intensive care unit, out on the floors, to be very sensitive to the particular type of changes that we have to look at and look for in a patient post-operatively to be certain that everything is going well and that they're recovering in the fashion that they should.
So if a patient's told by their physician that they think that they've got a herniated disc and they need to see a surgeon, how does one decide whether you go to a spine surgeon who's an orthopedist, a spine surgeon who's a neurosurgeon? How are those decisions made, and what difference in techniques are involved?
Right. Well, you know, I would love to be able to say as a neurosurgeon that the neurosurgeon is always the right choice, but the reality is there are well-trained orthopedic surgeons and there are well-trained neurosurgeons. And I would say that the only difference is that a neurosurgical residency, the period of training to which I referred earlier, exposed me to probably over 1,000 back operations. And so I got my training as a resident. In orthopedics, it's a much more specialized area, so generally the orthopedic physician will go on to do a specialized training period called a fellowship in spine. But I think that there is not a specific difference when it comes to the standard disc herniations or bony pathology of the spine. Once you go inside into the spinal cord itself, what's called intradural, the dura is the covering around the spinal cord. Once you open the dura, when there's a problem in the spinal cord, such as a tumor or an abnormal growth of blood vessels known as an arteriovenous malformation, then generally that is the purview and the area of the neurosurgeon, simply because that's where our training goes. It carries us through the dura to actually operate on the spinal cord itself.
Okay. You and I both trained at the same place at different times, the Columbia
Yes.
Presbyterian Hospital, the Neurological
Not
Institute.
too different.
Couple of years difference. And when many of my patients come to me, and I've been in practice for a while, and they are concerned about having procedures done on Staten Island. They say, I want to go to Manhattan, I'd like to go to place X, Y, and Z, whatever hospital you can mention. I know you were at Mount Sinai's group of hospitals for a number of years. What do you tell a patient who's saying they're considering surgery, but they're not comfortable having it done locally on Staten Island?
Well, you know, I got to tell you, I've only been here for several months, and thus far, I've never had to have that conversation with patients. I certainly would imagine it. My future may hold a conversation like that. However, the idea of coming to Staten Island to set up my practice in the area, on Staten Island, was to bring the neurosurgical expertise and the neurosurgical techniques that I'm comfortable with to Staten Island. And what I can assure patients is that the neurosurgical care that we are going to mete out here, depending upon the team, depending upon the ICU, all of those different parts will be in place. So I understand. I mean, look, I have friends from different parts of the country, and they say they want to come to New York for surgery, and I have friends in New York who say, well, I want to go to Minnesota for surgery. You know, so and I understand that. I think in the end, and this is probably the way I would honestly answer your prior question about orthopedics versus neurosurgery, the patient just has to feel it. They have to be comfortable with the surgeon. They have to have confidence in the surgeon. And that goes beyond technical abilities. It's also judgment, and it's also the way that they care for the patient. So I understand that there is going to be a certain percentage of the population that's going to feel that way, but I think that what we're doing here will, if nothing else, certainly reduce that.
And that's marvelous. It's interesting. I've been in practice now for about 25 years. And being in practice that long, that was the sentence that came to me when I trained at Columbia, was to come out here and bring specialty care to multiple sclerosis and other neurological conditions, to bring to the outer boroughs some of the skills that I've acquired in Manhattan as you are. And I think it's marvelous that you're doing it, and very, very happy about it. We haven't gotten to the brain yet. So, there's a lot of spine stuff, and actually, there are more spine surgeries than brain surgeries.
There are, and that's not as a result of any specific subspecialization, although that's certainly been the majority of my practice. The truth is that there are just more spinal problems than there are brain problems. And the bulk of which, as we've referred before, problems with discs and things like that, they say evolutionarily it's the price we pay for walking on 2 feet. Before us, for millions of years, we were on 4 feet. But the fact that we are now essentially upright puts a lot of additional pressure on our back, and that's the majority of the things that we see in the office.
I thought it was supposed to be played football and basketball.
Well, I'm
and
sure
don't
that
work
doesn't
out
help
during the
it.
week.
That's the weekend warrior syndrome and all that kind of stuff. But
So one of the myths and one of the things we talk about with neurosurgeons is that if you have brain surgery, and we will move the brain over, that your personality is going to change, that you're going to take someone who has one demeanor or acts in one way, and then after doing the surgery, it's going to act in a totally different way. What's your impression of that, and what's the reality?
well, look, you know, the brain, if not the seat of the soul, is certainly the seat of the personality. And there is no doubt that there are some surgical procedures that will have an effect, not only subtly on the personality, but on motor function, on language function. But the reality is what we are doing when we operate is we are trying to essentially, if not eliminate, then at least reduce those problems. Frequently, if I'm called to operate on an epidural hematoma, which is a collection of blood on the outside of the brain but inside the skull that occurs frequently as a result of trauma, it's because the patient has weakness, and my evacuation of the clot will resolve that weakness, will essentially improve them back towards baseline. Now, can I absolutely 100% guarantee that in all cases that patient will return absolutely to baseline? No. I mean, I wish I could, but the reality is there are certain things that are irreversible. The truth that I find certainly in the brain is you never quite know what is irreversible and what's not, or there are frequently times when things are much more ambiguous. Yes, the brain is the seat of the personality, and yes, the brain is where control of the arms and legs are. But when we're operating, it is frequently to minimize or reduce those problems and not to accentuate them.
And those are many people who are very, very sick. As we know, the tragic case of the actress Natasha Richardson,
Sure.
who had an epidural hematoma and felt okay for a period of time, which is not atypical, and then died because of the herniation or the pressure in the brain.
Right.
Let's talk about trauma a little bit. So you run a trauma center, part of the neurosurgical trauma center. In any trauma center, what kind of cases do you see with regard to in a neurosurgical way?
Yeah. I mean, you know, by and large, they are bleeding can occur. The kind of difference between the brain and most other organs, say in the abdomen and the liver, if you get a hematoma, which is the medical term for just a blood clot, if you get a collection of blood against your liver, what's going to happen is your belly will expand. So it's not really going to put pressure on the liver. Plus, if you compress part of the liver and it stops working, the liver can recover and regrow. Okay? Not only can the brain not recover and regrow, but the brain, as you can see, is in an entirely non-dispensable, rigid container. So if a blood clot starts to accumulate inside the skull, there's really no place for the brain to go. For those of you who have not ever experienced what brain feels like, it's essentially the consistency of soft tofu, which is just to imply that anything that has any specific mass is going to very easily compress that brain. It's not a very rigid function. And as a result, things like a blood clot can put pressure on the brain against the skull. So what I would say when it comes to traumatic surgical intervention, when it comes to neurosurgery, the issue is really timing, because what we want to do is we want to get that blood clot out, or we want to reduce the pressure as quickly as we can in many cases.
Tell me a little bit about technique. You were proud and talked to me, I think, a little while ago about some of the stereotactic CAT scans. Maybe explain what could be done in the operating room to do a few things. One, for the best outcome, of course, but just as we're seeing with abdominal surgeries, you mentioned smaller incisions, being able to go in with scopes and different ways of getting things out. What's happening in neurosurgery? Some of us have the concept that if you go to a neurosurgeon for brain surgery, you're going to have a big cut, your whole head will be wide open, and that how do they put it back together? It's almost like Humpty Dumpty in a lot of ways. But what kind of new techniques, and we talked about the stereotactic program, stereotactic CAT scan program, what's being done? What are you doing that's really putting some cutting edge type things available to us?
Right. Well, at the hospital, one of the things that we will be acquiring is essentially this computer-guided technique that allows us not only in the brain, but more frequently now in the spine, to help direct some of the surgery so that, as you alluded to earlier, so that the incisions can be smaller. This allows recovery to be quicker. There is less postoperative pain. Be not mistaken, however, there are still risks to these operations. Just because there are smaller incisions doesn't imply that we're not doing what we need to do, and those risks still exist. However, in general, what the literature is showing more and more now in the brain as well as in the spine, that these patients do better because they can recover quicker. If I can just finally refer to this model, this is just broadly, without getting too specific, this is how we do what is known as instrumentation and fusion in the lumbar spine. And we are now able to place these screws with stereotactic guidance through simple stab incisions of the skin so that we no longer have to make the large incision, and we can direct it right into the appropriate portion of the vertebrae called the pedicle. And that helps us keep the incisions down, and it helps us reduce complications.
While I have you, and it's such a privilege to have you here tonight, tell me a little bit about different kinds of brain surgery. What are the more common kinds? We talked about trauma where there's a hemorrhage, but people might have, what do we do? And we had a patient in common who had what might be a very low grade or not very aggressive tumor. What's the approach of a neurosurgeon who specializes in this to follow or look at a patient? Does everyone with a tumor need surgery?
No, actually not. There are specific types of tumors that are very slow growing or frequently will stop growing. And we will find these tumors only because the patient was in a car accident and the doctor in the emergency room decided they needed a CT scan of the head, and they see something. Patient is 55, 60, 70 years old, never had any problems, and probably never will. So it really depends upon the tumor type, it depends upon the behavior, and it depends upon what the films look like.
So not every time someone is told, and nobody wants to be told they have a brain tumor. I've done that, sad to say, very often in my career. But the idea that there are neuro-oncologists and neurosurgeons who specialize in this type of thing, the idea that our treatments have gotten better, and even with malignant brain tumors, our treatments have gotten much better with chemotherapies, with different immunotherapies. Things have changed dramatically with brain tumor. That could be an entire talk we would have amongst here and we do amongst ourselves. The idea that people are doing better with these things and having the availability of people who are expert in them, I think it really makes a big difference. People with aneurysms are now getting them clipped without surgery many times. People with tumors we're watching. So we're able to do a lot more, and sometimes by doing a lot less, in a sense. We're getting the outcomes we want without doing all the surgeries. Just one last thing I wanted to mention, and maybe I'll do it real quick because we're running out of time. Any idea, any thoughts, do you do any types of surgeries for strokes?
You know, really the bulk of the work that is done for strokes involves going into the blood vessels themselves. It's not surgery. The surgery I will do, this refers back to the traumatic intervention, we will, because when a patient has a stroke, their brain will expand, we may sometimes release some of that pressure by removing a portion of the skull to allow that not to compress the remainder of the brain.
Thank you so much for being with us. And I'll tell you that we're going to continue this conversation because we do it every day at the hospital.
Yep.
I work at Richmond University, as Dr. Cohen is there. And it's my privilege to have you at the hospital and basically be able to go over all the things that we could offer our patients now on Staten Island.
Thank you for having me. It was a pleasure.
Thank you.